Welcome to Chapter 37, Emergencies for Patients with Special Challenges for the EMT. Disability. So when working with patients with special challenges, we're going to use empathy and respect. It can be difficult to know the right terminology when you work with these patients. The term disability refers to a condition that interferes with the ability to engage in daily activity. The term handicapped should not be used. Developmental disability is a chronic impairment beginning at any age up to 22 years old, such as cerebral palsy, Down syndrome. Other disabilities can be the result of a traumatic injury or medical condition, such as multiple sclerosis, Parkinson's disease, stroke, or traumatic brain injuries or spinal cord injuries. Many patients live independently with accommodations. Some patients live at home but require special assistance, and other patients with more severe disabilities may live in institutional settings. Some patients live in group homes. There are a few group homes. There's a company here in the Camdenton area that does have group homes, and those people live in a regular home. They have chores, they go out and do things, they do various things. The group home part of it is that there are multiple people who live in the home, and then they have staff that comes in and out that take care of them. Terminal illnesses, these are conditions like end-stage cancer, heart failure, and Lou Gehrig's disease or ALS. They may prefer to stay at home under the care of family with the assistance from hospice providers, and they may rely on technology to sustain life or relieve pain. So they may have some pumps at home, they may have a vent at home, they may have a hospital bed at home, anything like that. Advanced directives specifying the types of emergency care the patient will accept are common, and patients and their families have special emotional needs as well. Obesity. Obesity is a body mass index of 30 or more. So to calculate BMI, you take your weight in pounds divided by height in inches squared times 703, and that'll give you your BMI. Patients are at an increased risk for multiple diseases, and it's a significant and growing problem among adults and children in the U.S. Special measures to care for obese patients allow them to assume a position of comfort, monitor their O2 sat, provide oxygen and ventilator assistance as needed. We may have to use a ramp positioning to maintain an open airway, which is where we're just ramping them up to a 45-degree angle about mid-back, so that way we get that earlobe to sternal notch line. Use gentle pressure when ventilating, and have enough assistance to lift or move the patient. Be mindful of the maximum load of your stretcher. Bariatric surgery can result in post-op complications and hypoglycemia. Homelessness and poverty. So homelessness is a state of not having a regular place to live, often because of the inability to afford housing. Health problems for these patients can include pneumonia, mental health issues, malnutrition, substance abuse, and HIV and AIDS. The lack of access to care means that conditions often go untreated until they become emergencies. Sometimes these are our frequent flyers as well, are these homeless people. These types of patients will call us, especially like during the winter when it's cold outside and they don't have any place to go, so they go to the ER to get warmed up and probably have a meal. Homeless women can be maybe victims of abuse, and emotional problems are common in homeless children. Poverty is a common cause of homelessness that occurs when the income is not adequate for the standard of living. So how do we approach these patients? With autism spectrum disorders, these are developmental disorders that affect the ability to communicate. Traditionally, assessment techniques and treatment protocols may need to be adjusted for the patient. Use the mnemonic ABCs, CS, when treating a patient with autism. So awareness, basic, calm, and safety. So awareness is a disruption of routine, is not well tolerated by patients. Literal perceptions make communication challenging. Some patients are nonverbal or struggle to speak under stress, and these patients may have involuntary escalation or meltdowns, and it may be due to overstimulation, social skill deficits, or excessive demands, and it may also be from unpredictable situations. The patient may know they are out of control, but be unable to regain control effectively. In the basic, keep your instructions basic and use clear, simple, precise directions. Ask basic questions, use less stuff. Keep your treatment basic and assess carefully because the patient may not offer typical complaints. Calm. So remain calm if the patient escalates or melts down. Use one-to-one contact accompanied by a caregiver. Keep a clear, controlled tone of voice. Offer empathy and compassion. Allow the patient to express concerns and frustrations, and take extra time. If the situation is non-life threatening, then just follow the patient's timeline. Safety. Begin treatment where the patient is found. Remove anything that may aggravate the patient. Do a head-to-toe survey, one step at a time. Tell the patient what you're going to assess next. Allow the time for the patient to ask questions. Consider taking breaks during the exam and let the patient tell you when they are ready to move on. Avoid restraining the patient as well. Medical challenges. So children with lung disease, heart disease, and neurological disease may live at home with their parents. These children often use medical technologies like tracheostomy tubes and artificial ventilators. Parents and caregivers are a valuable resource of information about these devices. Care of these patients is complicated by the lack of history information readily available for the EMT. So general considerations. So we do have advanced medical devices in the home. So when called to a patient with special challenges, you have to understand their challenge as well as their chief complaint. Medical advances have enabled many patients with serious conditions to live and work outside of the hospital. As a result, we're going to see devices that maybe we didn't previously encounter. And these calls may be related to a problem with the patient's device or for a medical or traumatic problem unrelated to it. You're going to respond to calls at private residences, nursing homes, and specialized care facilities. You want to become familiar with any special healthcare settings in your community to be prepared for these kinds of calls. You're going to meet and develop plans with the facility representatives. Typically that's done at the top with management, and then you're going to check whether your community has a program through the dispatch system and identify people with special devices. Caregivers are often trained and very familiar with the devices used by family members. So some questions to ask is, how has this problem occurred before? What fixed it? Have you been taught how to fix this problem? Have you tried to fix this problem and what happened? And they may also provide insight into the best way to transport the patient as well. Caregivers are your best option for some of these things that you don't know about, because they have been taught how to deal with these machines. They've been taught how to handle the patient, and they've been taught the ins and outs of that particular disease or problem. Assign a member of the EMS team to work with a member of the family on the medical device, and remember that a family member's training may fail when faced with a loved one's emergency. So a little gentle coaching may help them overcome their initial stress response. A calm, stable demeanor, along with their expertise, will lead to a positive outcome. The patient may be able to help with their condition, their device, and operation of the device as well. Ask about the device and any problems with it. Your approach depends greatly on the patient's mental status and baseline functioning. And always explain what you're going to do regardless of the patient's mental status. So an EMT's actions fall under specific regional and state scopes of practice. Confer with medical direction if the skill required is not something you are trained or allowed to do. Considerations include: is the problem with a device life-threatening? Do I have knowledge to fix this problem? Do I have supplies needed to fix this problem? And is it within my protocols or within my medical control authorization? Establishing a baseline. Baseline for patients with special care needs often falls outside traditional norms. You're going to determine what normal expectations are for the patient and determine what change to make EMS necessary. Patients are often the best resource for baseline information, so you can ask what is different today and why they felt the ambulance was needed. Family and caregivers can also fill in assessment details. They're often well versed in emergency procedures, and they can do things outside of your scope of practice. Use other resources to gather information about a disease or condition. Conduct research when the patient is non-emergent, and consult med control for additional information. Differentiate a patient's unique ongoing challenges from routine problems of everyday life. Routine problems may exacerbate chronic conditions, so don't focus so much on the chronic problem that you miss the routine problem. And conduct a standard patient assessment. So life-threatening primary assessment problems are a treatment priority, and that secondary assessment will help better define the nature of that day's problem. So some diseases and conditions that we may run into that may have medical devices at home include congenital diseases, which are present at birth. They may or may not be genetic, but congenital heart disease, cleft palate, and congenital deafness. Acquired diseases, these occur after birth, and they may be caused by exposure to trauma or a medical condition such as COPD, AIDS, and traumatic spinal cord injury. Some diseases can be congenital or acquired depending on how they occur. A patient with a chronic disease may experience sudden worsening of the disease, and a patient may also develop an acute illness. Acute illnesses may be more devastating because of coexisting chronic diseases. Respiratory devices, so non-invasive positive pressure ventilation devices, CPAP, BiPAP, both of these things are there. Typically, these patients use them at night when they sleep, and they help them to breathe when they're at home. Patients that use CPAP at night are unlikely to have any kind of emergencies related to the machine, and they may bring their machine to the hospital. Tracheostomy tubes. This is a surgical opening through the neck into the trachea. The tracheostomy tube is inserted into the opening to allow the patient to breathe. So BVM fits on the end of the tube, so that way if they're on a vent and the vent isn't working or something like that, then you can take them off the vent, put them on a BVM, and bag them. An obturator is used to help insert the tube, and I'll show you that when you guys come for skills. So an obturator is just a small plastic tube that goes into the tube to help it insert. Typically, these are done for conditions that affect breathing and airway patency for a long term. It's inserted into the opening to allow the patient to breathe. Again, they may not be on a ventilator, and they may or may not have the ability to speak. Mucus buildup is a frequent problem, and dislodgement and stoma infection may also occur. So, assessment transport, so you're going to check the tube for blockage. If it is blocked, we're going to insert a whistle tip catheter into the stoma, determine depth using the obturator or resistance. Suction as the catheter is withdrawn, cleanse the catheter with sterile water, and use a BVM between suction for ventilator patients, and then transport with the patient head slightly elevated. Home ventilators. So this is a device that basically allows the patient to breathe. These patients can be on a tracheostomy because they're on a long-term vent. They need the vent to be able to breathe. Again, common problems include mucus plugs and secretions, infections, and power or mechanical failures. Typically, these will have some type of battery backup though too. So use the DOPE mnemonic to help figure out what's wrong with the vent, if it's, if there is something wrong with it. So displacement, obstruction, pneumothorax or pneumonia, or equipment problems or failure. Cardiac devices such as pacemakers and defibrillators. It can be a pacemaker defibrillator combined, or it could be a pacemaker only. But pacemakers are typically given to patients who are in AFib, who do not necessarily see, or who have like AFib, who can't control their AFib with medications or something like that, so they need a pacemaker. Defibrillators are for possible like VTAC or ventricular rhythms when the patient has problems. AICDs are placed under the skin with wires inserted into the heart, usually implanted in the upper left chest. They detect life-threatening cardiac rhythms, and then a single shock is delivered. The nature of the call may necessitate ALS, provide high flow O2, and frequently reassess your patient. And if the patient does go into cardiac arrest, just start CPR and use an AED as indicated. Wearable cardioverter defibrillators. So this is a Life Vest by Zoll. So basically what this does is it's a wearable AED is essentially what it is. CPR can be performed on the patients. If you're going to do CPR and attach your own AED, it's probably a good idea to take this off of the patient, or at least turn it off. Ventricular assist devices. These are implanted mechanical pumps inside the heart that has a drive tube that comes out of the body and into a battery pack, and it basically pumps blood through the heart. And it really doesn't pump; it pushes blood through. So the left ventricle, doesn't actually contract. It just goes straight into the pump. There's a hole that the pump attaches to with a tube, goes into the pump, and then that pump pushes it out into the aorta and through the body. Patient will not have a pulse. They may have a blood pressure, but the blood pressure is a little bit harder to take with a manual. And they may have just an automatic blood pressure is the best option for that patient. So this is your LVAD, okay? It goes into the left ventricle, goes through a pump, and goes out. Again, they're not going to have a pulse. You can still do CPR on these patients. You can still do various other things. The biggest thing to make sure that before you do any of that, you make sure that the pack has batteries. You replace one battery at a time, and that your drive line doesn't have any kind of it's not broken or cut or anything like that. So that way, because if it is, they're not going to have a pulse. They're going to be dead. And fixing one of those things could bring your patient back.
Your HeartMate 3 heart pump is a left ventricular assist device, or LVAD, sometimes called a VAD for short. It helps your heart pump blood through your body. It has been surgically implanted just below the heart, where it is attached to your heart's left ventricle and to your ascending aorta, the main artery feeding blood to the entire body. The pump helps your heart by taking over the work of your left ventricle and pumping oxygen-rich blood to the body. The pump is made mostly of titanium. A small electric motor inside the HeartMate 3 drives the pump, providing blood flow similar to a healthy heart. Although the HeartMate 3 LVAD is virtually silent, it is normal to sometimes feel the pump working. To power the pump, a tube called the driveline passes from the LVAD through the skin in your abdomen. The driveline consists of two cables, the pump cable and the modular cable. One end of the pump cable is connected to the pump, the other end exits your body. The modular cable connects to the pump cable at the modular inline connector, and the other end connects to the system controller. Your HeartMate 3 heart pump is a left ventricular
All right, so cardiac devices, so those LVADs should be secured. Battery failure should be addressed by connecting the pump into AC source. And if the pump fails, it may have a hand or foot backup. VAD failure may result in cardiac arrest. Feeding tubes are used in patients who are unable to feed themselves and can't swallow. There are a couple different types. There's a G tube, an NG tube, a PEG tube. There's various other deals, and you can have dislodgement, infection, and clogging as well. Just use tape to secure the tube to the patient's body prior to transport. Keep the nutrient source higher than the tube, and put the protective cap in place to prevent any kind of leakage. I typically don't try to transport a patient unless they absolutely need it with it going. So. Urinary catheters are used by patients who have lost the ability to urinate or control. You can have an indwelling Foley catheter where it stays all the time, and then you can have your straight cath that doesn't stay in all the time. So during transport, keep the catheter bag lower than the patient. Try not to damage it. Look for any kind of urine discoloration or odor, and empty the bag if it's 1/3 to 1/2 full. Ostomy bags are connected to the site of a colostomy or an ileostomy. Typically not usually visible through clothing. Common problems include infection, blockage, and dislodgement. We talked about dialysis, so there's hemodialysis for renal failure, end-stage renal disease. It replaces the functions of the kidneys by removing those toxins and filtering blood. That peritoneal dialysis is where the catheter is implanted into the abdominal wall, and it runs typically at home overnight. Do not take a blood pressure on any arm with an AV fistula, shunt, or graft. Rupture of shunt, fistula, or graft causes fast and significant blood loss. So control bleeding, tourniquets, hemostatic dressings, all that stuff. Central IV catheters are surgically inserted for long-term delivery of medications or fluid. It's often used for IV chemotherapy or antibiotics. It's inserted via a surgical puncture to introduce medications or fluids into the central circulation. They may also have a PICC line or midline or a port. Any one of those basically is just access. Okay. An implanted port. We do not access ports at Mercy, but we can access like PICC lines and central venous lines and midlines and brachial lines and all that stuff. So we can access those, but we can't access ports. There are some services that do access ports, but we just don't. Use of catheter is restricted to hospital personnel on ports. Be aware of the catheter to avoid tugging or contamination. Do not place an AED pad over a central line, and have a high index of suspicion for sepsis. VP shunts are drainage devices from the brain to the abdomen or atrium of the heart. It is used to relieve excess cerebral spinal fluid. It is common in children with special needs. If the shunt malfunctions, then pressure in the skull rises, and it may cause an altered mental state. It may also be due to an infection, and patients are more prone to seizures and respiratory issues as well. Manage medical problems as you would for any other patient. Manage airways and prevent hypoxia, and just transport and consult med control. Physical impairments. So take the extra time to help care for patients with hearing, sight, or speech impairments. Remember that physical impairment does not mean mental impairment. So hearing loss, We're going to ascertain the patient's abilities. Can they hear me a little bit? Do I need to speak up? Do I just need to write questions and explanations on paper? Any of that stuff. Do they have impairments to sight? Do they have poor vision, or is it no vision at all? Carry a small flashlight and case lights have burned out. Carefully replace any objects you move, and transport a guide dog with the patient unless it is a threat. Aphasia, so allow the patient to write or type answers. If they have any kind of difficulty walking or standing, just carefully assist the patient. Bring along any helpful devices the patient wants. A wheelchair may make assessment difficult, and if the patient is moved to a stretcher, transport the wheelchair safely or secure it from loss. With a wheelchair, if you can transport it, great. If not, some of them are big and untransportable in the ambulance. But if the patient has a cane or a walker or something like that, then definitely take that with you. Provide whatever assistance the patient needs. Assess to determine whether the patient, whether the impairment is the baseline or is a new problem. Determine comfort levels. Explain your actions and treatments, and when transporting, bring aids required by the patient. We had a patient who used an iPad to speak, so he couldn't speak. I think he had a tracheostomy tube, and so he learned to speak with his eyes. So you put the iPad up, and it had a camera facing him, and he could look at the iPad and tell you what he wanted. Abuse and neglect. Patients with special challenges are more vulnerable to abuse and neglect due to their dependence on others. So just be alert to the possibility during scene size-up, history taking, and assessment. Watch for stories that are inconsistent with injuries, multiple injuries in various stages of healing, repeated injuries, and caregivers' indifference to the patient. Do not make accusations. Do your best to get the patient out of the environment and report your suspicions according to the requirements. Child abuse can take on several forms, often in combination, so it can be psychological, neglect, physical, or sexual. What constitutes neglect is a serious legal question. It can be lack of food, shelter, and a safe environment. Signs of neglect detected during calls for other reasons should be reported to the receiving physician and reported to the child abuse hotline. Physical and sexual abuse are types of most commonly seen. Physical abusers use many objects as weapons. They may beat with a hand or other object. They may burn the child with thermal sources. They may shake, throw, or push the child. And sexual abusers may expose themselves or engage in intercourse or torture. And it can result in serious physical injuries. And it can also cause unseen injuries. Common findings include slap marks, bruises, lacerations and abrasions, broken bones, fractures and fracture complications, head injuries, abdominal injuries, bite marks, burn marks, and any indication of shaking in infants. Repeated visits to the same child or children, indications of past injuries, poorly healing wounds and fractures, indications of past burns or fresh bilateral burns, many different injuries to both sides of the body, unusual behavior by the child, and a caregiver who refuses to leave you alone. So observe the adult as you treat the child. Do they seem inappropriately concerned? Do they struggle to control their anger? Do you fear a sudden emotional explosion? Does the adult appear to have deep depression? Are there indicators of drug or alcohol abuse? And do any of the adults speak of suicide or seek mercy for their unhappy children? Rearrange or remove clothing only as needed to determine and treat injuries. Examine the genitalia only if there is obvious injury. Be careful, calm and reassuring. Common signs are obvious signs of sexual assault, an unexplained genital injury, and seminal fluid on the body or clothes. Remain professional and control your emotions, even though it's going to be hard. We need to remain professional and try and control those. Protect the child from embarrassment and do not say anything that makes the child feel blame. Dress and provide other injury care as needed. Preserve evidence of sexual abuse. Discourage the child from using the bathroom. Give nothing to eat, nothing to the patient by mouth. Do not have the child wash or change clothes, and transport the child. Elders may be physically, psychologically, or financially abused or neglected. Physical abuse includes pushing, shoving, hitting, shaking, and several sexual abuse. Neglect includes improper feeding, inadequate hygiene care, and inadequate medical care. Psychological abuse and neglect includes threats, insults, and ignoring the elder. Financial abuse and neglect include exploitation or misuse of belongings or money. Dependent adults outside of the geriatric and pediatric population may also fall victim to abuse and neglect. They may have disabilities, developmental or physical, and just approach to recognize abuse as similar for children and elders. Unexplained absence of caregivers or potentially harmful periods of abandonment, signs of hunger, malnourishment, or improper toileting, improper or unusual interactions with caregivers, and the caregiver may interfere with assessment, treatment, or transport. Gather information from the caregiver away from the patient without expressing judgment. Talk with the patient separately on how the injury occurred. Control your emotions and provide appropriate care. Do not indicate suspicions of abuse. And if the MOI is suspicious, transport the patient even if the severity of the injury doesn't necessarily warrant it. You guys are mandated reporters, so you are required to contact the state social service reporting hotline. The state would like you guys to do an online reporting. So it's just a Google form that you go online and report through. So, yeah. Intimate partner violence is a pattern of behavior used to gain control over an intimate partner. It is a pattern of behavior, not an isolated incident. Abusers are physical, emotional, economic, and sexual tactics. And we often see these patients multiple times. EMTs may be the most sophisticated medical care that the patient receives. They may also are often the only outlet to social service referral. Assessment of the patient should take place away from the partner and any children. Look for signs of physical abuse, victim fear of talking to EMS or law enforcement, reluctance to accept treatment or transport, any kind of obvious signs, isolation of the victim, delays in seeking treatment, history inconsistent with injuries, and unusual interaction with the partner. This kind of abuse and violence typically is from kidnappings or there it is. It's on the tip of my tongue and I can't remember it. Human trafficking. So slave trafficking, those type of things, is again all of these signs and symptoms. So always attend to medical issues first. Patients often refuse transport due to calculated decisions about their personal safety. Try to be an advocate for the patient. Let them know community organizations can help. Note that these services are free and confidential, and point out any kind of 24-hour toll-free hotlines. If you don't know what they are, find out what they are in your community. And our role is to gather information, document statements, and objectively report facts. Human trafficking. So this is the exploitation of a person for compelled labor or a commercial sex act through force. It is a public health issue because it exposes victims to abuse, malnutrition, STIs, and mental health issues. EMTs are uniquely positioned to observe environmental situations that other care providers can. Okay. Clinical presentations: bruises in various stages, scars, mutilations or infections, urinary difficulties, pelvic pain or pregnancy, chronic back, cardiovascular or respiratory problems, poor eyesight or eye problems, malnourishment or serious dental problems, disorientation, confusion, phobias, or panic attacks. They may be accompanied by a controlling person. The controlling person does all the talking. They may have a language or cultural barrier. The ID may be held by somebody else. The patient may be submissive or fearful. They may be inadequately dressed for their job. They may be subject to security measures. They may live in a degraded place, and they may also have classical presentation of trafficking. Treat medical problems first. Remember that trafficking is perpetrated by sophisticated and dangerous criminals because they do it all the time and they don't want to get caught. And it's good money. Do not disclose your suspicions to others on scene. And if you suspect trafficking, law enforcement should be immediately and discreetly notified. With human trafficking, it can happen. We have it here at the lake. It occurs every summer, especially with us being a tourist place. So it occurs here at the lake, whether we want to believe it or not. We have human trafficking here. So if you have any questions, let me know, and I will answer them to the best of my ability.